All right, so hello everyone. My name is Sean Shellham. I'm a PGY4 CA3 at the University of Arkansas for Medical Sciences. This video is part of the ASRA Resident and Fellow Committee video interview series on recent fellowship graduates. Today, our guest is Dr. Justin Schapell. He's a graduate of McGovern Medical School at UT Health. He completed his PM&R residency at Mayo Clinic Rochester and also completed his chronic pain fellowship at Mayo Clinic Jacksonville and is currently practicing as a pain physician in Eau Claire, Wisconsin. How are you, Justin?
I'm doing excellent. How are you, Sean?
I'm doing well. Thank you for joining us. I guess I'll start with what I'll start things off with what made you decide to pursue fellowship in chronic pain?
Yeah, it's a fantastic question. I think if I had to boil it down to one main thing, really was about maximizing my skill set. So as you kind of mentioned, my background was physical med and rehab. But I really felt like after having gone through that in residency and doing a lot of reflection of how I wanted to maximize both my kind of clinical ability to diagnose various conditions and procedurally to have a lot of tools in the tool belt to treat a lot of various conditions. Definitely felt like pain medicine fellowship would broaden that skill set the most of all the options, at least out of that base kind of PM&R residency training. So that was the biggest thing.
Great, yeah. So it sounds like completing fellowship made you feel like you could fully treat the patients you were seeing in residency. Does that sound about right?
Exactly right. Yeah. Well said.
Awesome. Awesome. And so, as a fellow at Mayo Clinic Jacksonville, can you kind of describe a day in the life?
Yeah, good question. So I'd say, I mean, it varies, right? A little bit depending on the day of maybe how early you had to get there. But I'd say most days I was getting into work around probably six or so. Um, Maybe a little bit earlier at the start of the year, but once I got in kind of a rhythm. So I mean, that was my personal preference. I like to do a lot of my pre-charting and prep work
Hmm.
the day of in the morning, whether that was for clinic or procedures. So I get there pretty early to do that. But then I would start, seeing patients usually right at 8 a.m. or so 7 late, it's like 7:30 or so on sometimes. And then luckily, or late, well, depending on how people kind of work best, I was fortunate for how I like to operate, and that a lot of my days were not mixed. In that, if I was in clinic, usually I was in clinic the whole day, or if I was in procedures, I was in procedures the whole day. For the most part, there are a few days that would maybe be split half and half, like morning and afternoon. Um, and then yeah, between at the end of the day answering emails or managing kind of in basket things or prepping for a presentation or doing some research, I was usually out of work by 5:30, 6 p.m. most days. Again, there were days that you definitely got out early, and then days that I stayed beyond that, but that was probably on average.
Okay. Yeah, so it sounds like they had you like focus on everything for a day, but also get a good experience throughout the week, no matter what your days look like.
Yeah, and I mean the other thing I'll say is that I was fortunate, at least at Mayo Clinic Jacksonville, is that a lot of the priority was on giving their fellows, so just myself and one other co-fellow, the best kind of training experience. So if there was ever a procedure that we really wanted to be there for, or something we wanted more reps on, I mean, by and large, that was always facilitated. So I'd say there were some days that I even got to customize that schedule to kind of take advantage of whatever interesting procedures were going on that day or interesting kind of clinical evaluations. There was a lot of flexibility kind of built into things too. But yeah, luckily most of those days were kind of carved out. I was either seeing, my continuity clinic patients or seeing clinic patients and staff with one of my consultants or attendings, or I was in procedures all day long, like bread and butter fluoro stuff, or it was an OR day where I was doing probably two or three cases in the morning and maybe a case or two in the afternoon kind of thing.
Yeah. Outside of the your days in the OR and your days in like the chronic pain clinic, did you have any other rotations through your fellowship year, like maybe with other specialties or doing different things?
Yeah, no, fantastic question. So yes, to answer that, I'm trying to, even though it wasn't that long ago, you'll have to give me a moment to think back through all the ones I had. But for example, I rotated with the regional anesthesia folks. So like I mentioned, I think for those that train or come to train at Mayo Clinic Jacksonville, they try to prioritize giving you some exposure that's different than whatever your residency was. So myself and my co-fellow were both PM&R trained, so we got some time with the regional anesthesia folks to learn some of those kind of unique blocks that they do, learn kind of airway management, more of the anesthesia side of things. But I also got to rotate with neurology, a little two week rotation with them with palliative care. think was another 2 week rotation. We're also very fortunate to have had exposure to a comprehensive pain rehab program, which is pretty unique to Mayo. We call it the Pain Rehab Center, the PRC. So that was another 2 week rotation where you actually follow kind of a cohort of patients going through that comprehensive program, um, and see that kind of unique take on things. Quite the opposite of interventions and a lot of
Right.
what we do, but still good to see and definitely the right fit for certain patients. I'm sure I'm missing a few others. There were other opportunities. Like I could have had some time to rotate through PM&R if I would have liked. And the only one that is now coming to mind is I also had some time with radiology as well. I think it was another 2 weeks where I was more with a neuroradiologist, going over some films and learn how they read studies and their kind of systematic process. So yeah, a lot of kind of cool supplemental electives and selectives that I was able to take advantage of.
That's great. It sounds like they did a great job of, you know, exposing you to so many different like tools and perspectives that you can use as a pain physician in your
Definitely.
career. Awesome. Can you talk about like what your education didactic schedule was like?
Yeah, certainly. So I would say, I mean, education and didactics were a huge emphasis. That's kind of a running theme probably of all the Mayo Clinic campuses that's taken
Yeah.
very seriously, and there's some nice kind of carved out time for that. I would say off the dome here, I think our structure was that at least weekly. I believe it was Wednesday mornings. That was a kind of the scheduled morning didactic time. So that would be rotating topics. Say like one day was over the basics of fluoroscopy and getting different views and how to get like a true lateral in the C spine or a true lateral in the lumbar spine. But all the way to topics like buprenorphine and methadone, maybe opioids that we don't maybe as often kind of manage, and some niche topics like that. And then the stuff you'd expect, like intrathecal pump troubleshooting and ENS kind of basics, and such. So that was usually like a carved out time Wednesday mornings that we'd have one of our attendings lead those. To supplement that, though, we had journal club, which usually was a quarterly kind of a longitudinal kind of experience that the fellows led and I led. So we'd pick a topic. Usually it was actually really cool. We were usually investigating certain newer technologies or new interventions out there and talking about the evidence in an effort to then you're presenting right to the department of physicians and APPs, usually to facilitate discussion of whether we should be bringing that technology on and actually incorporating it into the practice at large. So rather than maybe just the pure academic debating about kind of an interesting topic, it was usually like a focused kind of journal club with intent behind it, which I thought was really cool. Just yeah, I don't want to be respectful of time here too, but there were other opportunities too. We had a longitudinal research kind of curriculum built in that was led by, for those involved in ASRA, maybe you know the name Christine Hunt because of how big of an influence she has within ASRA, and just led the past meeting there in Vegas and did a fantastic job with that. She's one of my dearest mentors, so she leads that for the fellows, and kind of meets fellows where they're at, whether they have a lot of research experience, which is like myself and my co-fellow, but usually then can either structure that research, either teach you the basics and maybe give you a few projects to kind of sink your teeth into, or if you have some research background, really she's really good about giving you some roles to have and projects to build on throughout the year. So that was there too. Last piece I'll say, I know it's a long
Oh,
one to answer because there's so
that's
much to talk
great.
about, is that
Yeah.
we have a structured ultrasound curriculum too, thanks to Dr. Mark Hurdle. And so that included every week we had some hands-on practice sessions, scanning each other, scanning attendings that the sports medicine faculty at Mayo Clinic Jacksonville led, along with Mark Hurdle, who's a pain physician there at Mayo Clinic Jacksonville. And that was sprinkled with a few sessions during the year where we have a cadaver lab at Mayo Clinic, Florida, where we would go in cadavers and practice maybe some of the more advanced kind of ultrasound injection techniques on fresh kind of frozen cadaver sections to get reps in that.
Yeah. I love that. It sounds like, they challenged you, not like with that journal club, um, to discuss like what should be brought into the fellowship and the program, but also, you go to these ASRA meetings, you see all this new developing technology every year, and as an attending, you'll need to be able to navigate what you should provide to your patients, and it's great that they already give you a head start on that as a fellow. Um, what talking about procedures and technologies, what everyone loves about chronic pain these days. Uh, Can you talk about your procedural exposure at your fellowship, the types of procedures, how many did you perform, and maybe what procedures you wish you had more exposure to?
Yeah. So fantastic question, and definitely a question that people are always eager to talk about. So I'm happy to and I'll give some raw numbers. I actually had the privilege of putting together a presentation for the department at the end of the year. So luckily I jotted down some numbers in front of me here. So I'll be glancing down at that because I can give
Awesome.
pretty accurate ones. Through June, actually, my fellowship wrapped up for me kind of June 30th or so. But at the very start of June, when I put together the presentation, I was already at high 900s in terms of overall procedures. So by the end of fellowship, I had eclipsed 1,000 just myself, and those were the procedures that, yes, with attending kind of supervision, but that I individually did. Um, for us, I mean, I was mentioning the ultrasound emphasis on the didactic side, but on the procedural exposure side, that was actually 400 of those 1,000 or so procedures that I did were ultrasound based, and then 600 being more the floor or OR cases. So just over 1,000 procedures total. I thought at Mayo Clinic Jacksonville, I got great kind of advanced exposure. And that so raw numbers here myself, Michael felt very comparable numbers, but I had 12 SCS trials, 16 implants for a total of 28 SCS cases, five peripheral nerve stem trials, and three implants, total of eight. I had eight basivertebral nerve ablation cases that I did, four reactivates, two intrathecal pumps, seven cryoablation procedures, and then one DRG trial and one DRG implant. So really across the board, I mean, as far as the
Yeah.
more advanced things that are out there, I feel like I got really, really good exposure kind of across the board and on that spectrum. But then all your other kind of more even niche fluoro procedures, celiac plexus blocks, stellate ganglion blocks under ultrasound, um, lumbar sympathetics, all the other stuff that, are usually fundamentals of most training programs, but maybe people don't get high numbers. I was able to get really good numbers on. Um, in terms of maybe what I would have wished, maybe or to have exposure to in hindsight, there are some of those other niche things. I mean, we're all hearing about at conferences. I'd say mild is one that I think the group down there is just about to bring on, but all my mild exposure was going to conferences and workshops throughout the year, but didn't actually have cases during fellowships. Maybe that was one opportunity that maybe I would have liked to have a little bit more hands-on time with that. Otherwise, interspinous spacers were something that we were still talking about as a group down there at Mayo Clinic Jacksonville that they hadn't brought on even by the end of my training. That might have changed by now. And then SI fusions, I guess would be one other thing. And again, some of the data on this is, I mean, that's the subject for a different
Yeah.
thing, but of much debate. But those were
Yeah.
probably the big three that I can think of. As far as I didn't get exposure directly through my fellowship training at Jacksonville, I had to kind of supplement in other ways. And the other thing is, I mean, two pumps. I maybe wish I had a little bit more pump exposure. I think that's more of a procedure that, depending on the area that you're practicing, if you see a lot of cancer pain patients,
Mhm.
could be very relevant. So maybe that number could have been a little bit higher. And I'm sure there's programs out there would give higher intrathecal pump numbers, certainly than maybe what I got throughout the year.
Yeah, it sounds like they gave you a great diversity
Yeah,
of procedures that you're exposed to, and you can correct me if I'm wrong, but all these new procedures build off your knowledge of anatomy and your technical skills from the older procedures. So the more you do across the board, the more it can lend you to do when more procedures and technologies are developed.
100%. Because even those ones I mentioned, maybe I was in the single digits. Maybe that was towards the end of the year. There was that foundation built that wasn't so, even though it was a novel procedure, operating a fluoroscope or instructing a rad tech of how to operate a fluoroscope to get a good view, the understanding of the anatomy and where to avoid that could get you into trouble. All that stuff kind of builds on itself, and it's easier than maybe it sounds to pick up a new procedure once that foundation is kind of set, for sure.
Yeah. Before we move on, just a couple more things about specifically your fellowship experience. I'm an anesthesia resident. You were a PM&R, you're a PM&R physician, and you came out of PM&R residency. How did your background as a PM&R resident influence your fellowship experience? And do you have building off of that, the next following question would be, do you have any recommendations you have to incoming fellows, maybe specifically PM&R fellows?
Yeah, great question. And can you repeat the maybe the front part of that question? I want to make sure I answer it as specifically as I can.
Yeah. How did your specialty background as a PM&R physician influence your fellowship experience, if it did at all? And do you have any advice for PM&R residents going into chronic pain fellowship?
Yeah. Okay. So no, thank you. So I would say, yeah, it certainly the PM&R background, I think for me personally, and I think for some others that I talk to, I will say provides maybe a strength in that in some regards, as far as like continuity clinic, for example. And so I know continuity clinic can be quite a daunting experience from what I've heard from maybe my friends who are anesthesia background and maybe don't have as much of that clinic exposure. But I will say that, that in fellowship was more of a position of kind of comfort or place of comfort when I had my own pain continuity clinic, and I was already used to that in residency of, performing those comprehensive kind of clinical physical exams and to managing kind of patients longitudinally when, you recommended one thing and maybe it didn't work. So now you have to plan a step B or plan B or so. So I think that came a little bit natural and wasn't so jarring of an experience to take on that responsibility to have your own kind of cohort of patients that you're managing. I'll also say that, and this was, I don't know how true this is across the board for PM&R trained residents, but coming to fellowship out of Mayo Clinic in Rochester, there was such an influence on ultrasound
Mhm.
that it was also a little bit easier for myself and my co-fellow, who was also my co-resident from Mayo Clinic Rochester, to really hit the ground running in terms of ultrasound procedures because of that foundation that was already kind of cemented in as far as MSK ultrasound, peripheral kind of nerve scanning. Some of that was more of there was already kind of a skill set there that certainly we refined and built on during the fellowship year, but at least that again that foundation was there to tie back into maybe the concept of learning new advanced pain procedures. That was, I think I was fortunate to have that and gave me at least some advantages in those regards. I would say my advice to though people that are coming from a PM&R background like myself and to pain fellowship is definitely recognize where you're lacking, where you don't have the experience or the kind of like niche expertise that someone from an anesthesia background has, or emergency medicine or family medicine or whoever maybe is in your program or the faculty that you're training with and their kind of unique backgrounds. I think um, I would encourage anyone to kind of like always be asking the about those subjects that maybe you're less familiar. So I mean, this is going to sound overly simplistic, and I know I'm picking stuff that, or I'm about to mention stuff that maybe seems um, like an oversimplification. But for instance, I mean, I don't know how many PM&R residents have that much experience seeing local anesthetic toxicity and knowing the symptoms to kind of be monitoring for that, knowing the treatment for that, knowing what a kind of high spinal anesthesia like again would look like in that kind of complication. So I think over the year or over the course of the year, I became a lot better about, even if we weren't obviously, I didn't ever see last in my fellowship year, thankfully. But I think asking a lot of your attendings or your co-fellows that have different backgrounds about, hey, like, have you ever seen this? How'd you manage this? If this were to happen in the case, like, how do you think about that from like the anesthesia background? To kind of pick the brain and of people with kind of different base training than yourself, I think can only serve you better in the long run, especially now when you get out on
Yeah.
your own and you're kind of solo in some situations and you don't have that sometimes always immediately readily accessible in your day to day once you start actually work. I think the more and more you can take advantage of that during the fellowship year and picking kind of the brains of those with different like backgrounds can only serve you well.
Yeah. Thankfully, even though I'm an anesthesia resident, I haven't had much experience with managing last or high
Okay,
spinal,
good.
but
Yeah,
the knowledge is there on how to do it.
sure.
I'm glad they were able to impart that on you as well. Um, Moving on from the fellowship side, I know we're running out of time, but one thing I really wanted to ask you about was um, your exposure to the business side of pain medicine at your program, and then also the job search process.
Yeah, so I mean, I can probably be quick on the business side of medicine. I wouldn't say that that was as much of an emphasis during my fellowship year. I mean, there were a few of the faculty members I was fortunate to work with who did come from some years of within in private practice, and then the teaching on the business side was more in conversations in between procedures or discussions about, you know. the Mayo kind of model of the business side of things is very unique, and that there's not a lot of that kind of cost consideration that always necessarily needs to be factored in. A lot of it's just we are fortunate if you're in the Mayo system to kind of do what's in the best interest of the patient, and then there's a lot of uniqueness behind the Mayo kind of like financial model that allows us to do things that are just not real world and not feasible. So that's probably a separate discussion. So I wouldn't say there was that much in that outside of picking the brains of my attendings that had that private practice background and getting some of their wisdom. Running the second question. This one I think I could maybe more speak to.
The job search process,
Job search process.
and how
Yeah.
your fellowship maybe helped you with that process.
Yeah, so my experience with that was also probably a little unique in that I had started to look at jobs actually at the end of my residency,
Mhm.
my fourth year of PM&R residency. I was already starting to reach out to a few places and cold email around, and I was fortunate to actually get a foot in the door of actually where I am at now at Mayo Clinic Health Systems in Northwest Wisconsin. I had reached out to a recruiter when I saw a position kind of open up there, so I was already interviewing for the job that I have now in the summer in between my last year of residency and starting fellowship. And I signed my contract in August. So my situation is probably very unique compared to where most people are at. That's not, I think, the norm and not where most people are. They usually end up finding and interviewing for jobs during their fellowship year. Um, but it worked out well for me. I kind of knew I wanted to stay within the Mayo Clinic system and so it ended up being a good fit. But I'd say that the faculty at Mayo Clinic Jacksonville for my co-fellow who was not in that situation were very instrumental in that and kind of helping him navigate where he wanted to end up kind of career wise. And fortunately, he's actually staying. He's going to be coming on staff actually and working for Mayo Clinic Jacksonville as one of the new attendings here pretty soon. So they were very instrumental in guiding him through that and mentoring him. And then he was, able to interview and will be coming on staff there shortly. So they were very supportive. And definitely have a track record of helping fellows find a good kind of fit, whether that be in academics or within Mayo Clinic versus going out into kind of the private practice setting. There's a lot more kind of fellows over the past years that have more gone into that, and there's been good connections that the faculty at Mayo Jacksonville can utilize to find them good jobs to start out with.
Yeah, it sounds like you really, felt like found a home in the Mayo Clinic system, and that's why you still practice within that system in Wisconsin.
Definitely, yeah. It's I'm very fortunate to be where I'm at. That's for sure.
Oh, awesome. I'd love to hear it. And so we're kind of running into the end of this video. I'm sure we could keep talking about this stuff forever, but in the interest of time, do you have any, closing remarks for, any residents watching this thinking about applying to pain medicine, currently applying or incoming fellows into the field?
Man, yeah, closing remarks. No, I mean just encouragement. One, I think, pain medicine is I do despite its challenges at times, which
Mhm.
probably we're all too familiar with. I would say it is still it's a bright field. The impact you can make on patients' lives that are really struggling and really in a hard spot with pain that's quite debilitating, like the difference you can make by being a good clinician, first and foremost, and having a good bedside manner and being a good proceduralist. I mean, the amount of impact you can have on people's quality of life is significant. So I would say that this is probably not new advice, but I'll be one more person to say your fellowship year will go by very, very quick. Definitely try to soak up as much as you can, but do not get lost along the way and always just thinking that you need to be the best proceduralist and learn all these new procedures and be the quickest person kind of in the room at them. I'd say you're going to be much better served, like we kind of talked about before, forming that foundation, like
Mhm.
understanding basic fluoroanatomy, basic MSK anatomy, knowing the right indication for certain procedures in which patients are most likely to benefit, be able to be that pain doctor that can give people realistic expectations and a realistic diagnosis of what's going on so that you can kind of set expectations, and expectation management is so huge. I think if that's more the foundation that you get from fellowship, all while building a great kind of like pool of mentors that you can reach out to when you're like myself a few years or sorry, a few months kind of just out of that, and then still trying to learn things, as we all will have to as we kind of go along. I think that foundation, that mentality is going to serve you well to stay motivated, to see the good parts of this field, and to not get kind of lost along the way. So that's probably what I would encourage anyone kind of listening to this to keep in mind and keep in perspective as they're applying to or about to start pain fellowship.
Yeah, I love it. I think that's an excellent message. You got me going. I'm going into fellowship
Of
next year, so thank you so much. Well,
course.
on that note, that concludes our interview with Dr. Justin Schapell, who once again chronic pain fellowship graduate at Mayo Clinic Jacksonville, and currently doing good work in Wisconsin. Thank you, sir. And then to all you watching, thank you so much. Remember, support ASRA. Join if you're not a member. We'll be coming out with more videos just like this. Thank you all.